Okay, ya que maybe we can eso. Hello, everybody. Welcome to our multicultural Alzheimer's prevention program, MAPP Rounds. I am Liliana Ramirez Gomez. I am a behavioral neurologist, director of the clinical director of the Memory Disorders Division at Massachusetts General Hospital and faculty at MAPP. Today, we have the great pleasure and honor of welcoming Dr. Suvarna Alladi. Dr. Suvarna Alladi is Professor of Neurology, National Institute of Mental Health and Neurosciences in Bangalore, India. Dr. Alladi was a Commonwealth Research Fellow in Cognitive and Behavioral Neurology at Cambridge, UK. She established one of the first memory clinics in India that provides multidisciplinary care to more than 3,000 patients with dementia. Her areas of interest are cross-cultural cognitive assessment, frontotemporal dementia, atypical Alzheimer's disease, and vascular cognitive impairment. Dr. Alladi's group coordinated a multicentric study that adapted cognitive tests for different Indian languages and for illiterates. Her work also focuses on investigating the influence of life course experiences that include bilingualism, education, and social engagement on cognitive resilience. In the background of a rapidly rising burden of dementia, creating awareness and organizing community support for dementia became a focus of the Alzheimer's disease NGO she co-founded. Dr. Alladi has also made an effort to represent priorities of less developed societies in international platforms and meetings. She is World Dementia Council member, chair of World Federation of Neurology, special interest group on aphasia and cognitive disorders. Welcome, and thank you so much for being here, Dr. Alladi.
Thank you, Liliana, for this, for your kind invitation. It's such an honor to be here. I'd like to thank Yakil, an old friend of mine, who has been, I think your lab represents not just cutting edge research in multicultural neurology and neuropsychology and dementia, but are also very strong advocates for the field. And I know Yakil is a fantastic mentor. And so it's indeed a real privilege to be here and to be invited and to participate in the MAPP rounds.
And to our audience, please feel free to put any questions you may have in the QA, and we'll have a time at the end for Dr. Alladi to answer our questions. Thank you.
Yes. So I'd really like to start with how we are supposed to diagnose Alzheimer's disease today. This is the NIA Alzheimer's Association research framework, and we are moving towards a biological definition of Alzheimer's disease. We're moving towards developing biomarkers for Alzheimer's disease. But what I'd like to point out is that we still need to look at test cognition. We really need to understand how people use their cognitive abilities to interact with the world. And therefore, that dementia diagnosis is very crucially dependent on cognitive assessment, understanding a person's cognition in his or her own, in their own environment. And I think that is something that we should not forget. And that's why especially in multicultural world, like the world that we live in. And why this is important is most cognitive tests, as most of you are aware in this group, have been developed assuming a certain normal, literate people, monolingual, and culturally Western. But we also know that cognitive and behavioral assessment has to be done using standardized and validated tests that detect both the nature and severity of cognitive deficits and how they impact an individual's functioning. However, diversity characterizes our world. There is linguistic diversity, there's occupational diversity, there's educational diversity. This is the biryani that you would eat if you were in India, in Hyderabad. This is the rangoli or the floral pattern that all women, use to mark auspiciousness. And there are many different cultural practices that in some form or the other impact our well-being. And they differ across the world. Similarly, there are differences in the burden of dementia in different parts of the world, while the prevalence is actually stabilizing in the high-income countries. Countries which are less resourced are facing a very high burden of dementia, and the numbers of people living with dementia in our parts of the world is only going to increase. Closer to home in India, a recent study demonstrated that the prevalence of dementia in adults above the age of 60 years is 7.4%, which is really this is a rapid rise in the prevalence of dementia that we have observed over the past few decades. So this is a problem that we are all facing in the whole world. And therefore, when we are talking about dementia diagnosis, it's about people living with dementia across the world that the diagnosis should be relevant for. And this is Emily Ong. She's an advocate for early young onset dementia from Singapore. And this is what she has to say: nothing about us without us. Diversity impacts dementia in many different ways, as I will talk about in the next few minutes. Sociocultural diversity, linguistic diversity. There are differences in disease profiles, etiologies of dementia. There's genetic diversity, variability in healthcare practices, differences in government policies, and all of these impact all aspects of dementia from diagnosis to care. Firstly, linguistic diversity. As of 2022, there are more than 7,000 languages spoken in the world, and these are not uniformly distributed, but linguistic diversity is the norm in most parts. And if I were to take a show of hand for how many of us in this group are bilingual, and I'm very sure that it would be very high. And that's indeed the case in most parts of the world. And that is because it's language contact that leads to bilingualism. It's indeed very difficult to find a society that is genuinely monolingual. No language group has ever existed in isolation from other language groups, and the history of language is replete with examples of language contact leading to some form of bilingualism. In India, we are a very diverse country linguistically. There are more than 122 major languages spoken, 22 official languages, and more than 1,000 other languages and dialects that are spoken. And a significant proportion of our population is bilingual, and even or more than 2 or 3, 4 languages even. I speak 7 languages, and that's not considered to be any form of an achievement, because most of us do speak 3 or 4 or more languages because of linguistic language contact. And this is a map of India. And indeed, we are divided according to linguistic zones. So each state would speak a different language. This is Gujarat, would speak a language called Gujarati, Marathi in Maharashtra, Telugu in Telangana and Andhra Pradesh, Kannada in Karnataka, Malayalam in Kerala, Tamil in Tamil Nadu, Hindi in the heartland, where there are so many different dialects, Assamese, Kashmiri, and Punjabi. And these are all languages which are spoken, Urdu. There are so many different, Oriya, Bengali. So you can see that there are so many different languages that we speak across and very actively so in Indian context. And this has been the case for more than hundreds and hundreds of years. And we've been, different people have ruled different parts of India, and depending upon the political patronage and migration and trade. People learned different languages, and this is indeed how bilingualism and multilingualism is a norm in India. This is a memory clinic in Hyderabad that I first started. And it is very difficult for us to predict which language the person who walks into our clinic will speak. So we have to constantly be ready for, and it's done automatically. And if you're asked how we decide which language you talk to with the person, there must be so many nonverbal cues that we are getting, which make us speak most of the time the right language when we have a look at the person. And here, this is a lady who has dementia. She speaks Telugu, but her daughter speaks, she's a software engineer in America. She speaks both Telugu and English. Her professional carer is illiterate and speaks another dialect of Telugu. And my psychologist, Safia, those days, we used to talk to each other in Hindi or Telugu or English, depending upon what we wanted to say to each other. These are the newspapers that are sold, and most of our houses will have newspapers of 2 or more languages, and the political content in them will vary a little depending upon which language newspaper it is. So it makes for complete understanding of a situation when you actually read newspapers of different languages. So we looked at the profile and pattern of language use in Hyderabad to begin with when we started the memory clinic, and to understand what languages people were speaking at home, in informal situations, and in more formal settings. And you can see that the combination of languages varies depending upon where we are using them. Language context decides the language that we choose to use. But in the clinic, this is the picture naming, a part of the Edinburgh's cognitive examination, a 100-point scorer that is used widely. And this has been developed in Cambridge in England. And you can see the picture stimuli here. And that was the first step that we undertook, was to adapt it for Indian languages. But if you look at this was way back, really. This was about, I think, 2005 or 6. When the psychologist, she would ask me, Shailaja would ask me, Madam, in which language do I have to, score them? And then, it was very clear, then you have to use the same language. But our patients don't follow those rules because we mix languages all the time. So pencil was in English, watch was in English, but the goat the patient would say meka or a goat. And the candle would be candle because it's a borrowed English word. Flag would be patam. And giraffe, we don't have giraffes in India, so we use just the word giraffe. And similarly, we had to first figure out how to score people so we get the best of their cognition out, so we can make a fair diagnosis of dementia or not in them. So that was the first step that we did. We adapted and validated the Edinburgh's cognitive examination in I think 8 Indian languages across the country: Hindi, Telugu, Kannada, Malayalam, Urdu, Tamil, Indian English. And these are the different scripts that you see. And this we find to be a good tool to screen people for dementia and also subtype dementia fairly well using this tool. But that is a cognitive screening tool. So it was important for us to standardize dementia diagnosis with neuropsychological test batteries that were being used across the world. So we took up this exercise of developing what is called the Indian Council of Medical Research Neurocognitive Toolbox, by reviewing several different neuropsychological batteries that were in use: the CERAD, the NINDS, Canadian Stroke Network, the 1066 battery, which was used across several low-middle income countries, and also the cognitive test batteries that were developed in a particular region of India, the Hindi cognitive screening battery, the Kolkata cognitive screening battery that is in Bengali, and we came up with a multidisciplinary group of experts came up with the Indian Council of Medical Research neurocognitive toolbox, and these had the range of tests that are required to make a proper cognitive profiling of a patient. So we had tests for attention, episodic memory, language, visuospatial functions, neglect, and several questionnaires to assess activities of daily living and behavior and wellness as well. So these are some of the adaptations that we made. We have many illiterates, so the complex figure had to be simplified. We use the format of the stick figure with scoring that we use for illiterates. This is the FAST, the French aphasia screening test. So the picture of this man walking his dog had to become a farmer with his goat in order to elicit the right kind of responses from patients who might have aphasia. And this neurocognitive toolbox for dementia was validated for dementia first across 5 different languages, and it's also validated now for mild cognitive impairment. So it's found to be quite sensitive and specific for the diagnosis of mild cognitive impairment. I must admit that the researchers on this group were mostly neurologists, some speech and language therapists, and I think there was one clinical psychologist. So it was a challenge, but it was mostly driven by the need of patients that were entering our clinic and our need to, write about them. So if you do not have a standardized tool, those people are not represented in research. So if you want your population to be represented in research, to get the benefits of research, we really had to develop tests that would tap into their cognition the way the rest of the world was doing. We have a large burden of stroke, so that the cognitive test battery has been derived from the NINDS, Canadian Stroke Network. So we were able to modify it for stroke population. MOCA, an increasingly common cognitive screening tool, has also been adapted to several different Indian languages. And to deal with the problem, or not the problem, but the issue of bilingualism, we studied several bilinguals with the neurocognitive toolbox, and we came up with some recommendations for the Indian context on how to test bilinguals. And I think many of this would hold good even for any country or any memory clinic where you're testing bilinguals. So our recommendations were that you have to evaluate the linguistic proficiency of bilingual speakers using some subjective or objective measure before you start doing the cognitive examination. And cognitive testing is ideally to be administered in the most proficient language of the speaker. So you are not underestimating their cognition because of their poor proficiency in a language you're testing them in. And the linguistic proficiency of the examiner also has to be evaluated using subjective or objective measures, because this is not a blood test or a standardized test where the machine will behave the same regardless of what you put in, or that's what we believe. But here we are dealing with human beings testing other human beings. So you need to have linguistic proficiency of the examiner, and the examiner administering the test has to be fairly proficient in the target language used for testing. And to deal with the issue of borrowed words and language mixed words, which we all use all the time, they have to very carefully and systematically be considered while interpreting responses during bilingual testing. There is evidence that people with semantic dementia, for instance, lose a second or third language, so they would speak in their mother tongue mostly. So you do not want to miss that finding. At the same time, a lot of us use mixed words in our day-to-day language, and if you were to score people less because they used an English word or a word from other language, you would be underestimating their cognition. So while it is complex, it is something that is worth doing so you can actually make a good diagnosis in the person you are evaluating. We also looked at the scores that people, of scores of people of monolinguals and bilinguals. And while there is considered to be a bilingual advantage in certain cognitive functions, in the clinical diagnostic setting, we didn't find a need for separate norms for monolinguals and bilinguals, because in the test, neuropsychological test that we used in this battery, both monolinguals and bilinguals were performing on par. So these were some of the recommendations that we put out for use in our context. You can see all the different languages that our patients spoke here. And yeah. And this is the multilingual dementia research and assessment tool, now called Mudra, which has been standardized for across 5 centers in India in more than 1,500 people. And the other advantage with this test toolbox is that it's absolutely free of copyright. So you can see here the trail making test, category fluency test, the Dave Ostreit figure test. You have to pay for use, and it's something that is not accessible for most of our clinics. So we reached out to researchers who had developed tools and who very generously shared those tools with us and said, you don't need to pay any money. You can use it. You have a permission to adapt it in your language. So it was also a very gratifying experience to reach out to all these researchers and come up with a toolbox that you can just click on this link and download all the tests and the norms. All you need is to write this email to Indian Council of Medical Research, informing them a very simple form. And within a few weeks, you would get a response saying you could go ahead and use it, provided there is some trained psychologist on the team or a cognitive neurologist on the team to use these tests properly and get trained on them. And now, so these are all the various disease etiologies that we can study because we have a range of cognitive tests. We're also able to build harmonized cohorts across rural Haryana, urban Bangalore, and tribal Shillong through a dementia science project that we are currently doing. Right. So now I will move to the other challenge that we have, and that is illiteracy. So we have people who are very literate, but at the same time, we also have people who have not undergone any formal education. In fact, 1/5 of the world's population are indeed illiterate. And in India, the illiteracy rate is still very high. It's 26%. Several children do not go to school, and the dropout rate is quite high. While we do have a compulsory education for all policy, it is still going to take some time before the entire population learns how to read and write. So you have this old gentleman who comes to us. These are all his grandchildren. Grandfather has difficulty remembering our names. So at that point, we did not have a tool that evaluated his cognition properly because he could not read and write, and most of the cognitive screening tests require some form of literacy. And the reason why these tests do not work very well for illiterates is illiterates have difficulty in visual discrimination, processing 2D images that we typically use in our paper and pencil tasks, and then you have dot counting. So different kind of visual search. The way they learn and retrieve is not through lists. And also they have problems interpreting literacy-based symbols. So these are some of the problems with the cognitive tests that we are using for illiterates because they do not have a framework to actually translate our cognitive tests, map our cognitive tests onto their cognitive abilities. On the other hand, when we went and visited his house, he lives in his house that he built, and he has 4 sons and 4 daughters-in-law, and he has about 6 grandchildren, and they all take turns to look after him. So he was quite cared for. and respected as a revered member of the extended family. And they just considered that, he was just aging. So making a diagnosis of dementia in a person like this, and there are so many different examples like this, was going to be challenging for us. And these are some of our illiterates. The farmer who knows how to use a smartphone, the helps at home who just keep homes running so well and multitask and have such high social understanding. The weavers who are able to make these complex crafts. Our auto drivers who know how to take us all around the town, so and still charge us so much more without knowing sometimes how to read or write very well. Flower sellers who know their craft so well. And then the tribal women who have a completely different understanding of the world that is inaccessible to us. So these are some of the illiterates that we are talking about. And what are the challenges in evaluating such illiterates? If we do not carefully consider educational variables, neuropsychology runs the risk of finding brain pathology when actually these are only due to educational differences. Now, this was one study where in a 530 subject sample of individuals with diverse educational backgrounds, while educational level represented a significant predictor in the MMSE scores, the cutoff point for illiteracy had to be set at only 13 points out of 30. And this for any educated person is significantly abnormal. So just bringing down the cutoff scores is, while it is true that illiterates may not be able to do some form of sophisticated cognitive functioning that is related to literacy, it might also be that they're very functional and that is not getting captured in our cognitive tests. So these findings only stress the need and urgency to develop valid and reliable measures that actually capture their cognition. So the first step that was done was to adapt MMSE and other similar cognitive tests for illiterates. Just today, about a few hours ago, we finally managed to write up our illiterate Edinburgh's cognitive examination. The cognitive testing tool, it's just come online. And some of the adaptations we made were to use colored pictures and to use simplified pictures that resemble the rangoli or the floral pattern that illiterate women are used to making. The clock was converted into this face that can be, draw a face with, eyes and nose, and you can score it. And then you have these irregular words, which in Indian languages anyway, we do not have irregular words, but it is a sign of, it is meant to pick up semantic dementia. And then, so what we did was we had a semantic association task here that is working quite well among our illiterates. But moving on, we felt we needed to have performance-based tasks to assess cognition among our illiterates. And these are more real-world problems which are embedded within instrumental domains. Most of our daily functional activities require cognitive abilities. And the degree and pattern will vary whether, one is healthy or has cognitive impairment. And the range of things that one does are, while a lot of them are common among people, we thought we should make a battery of performance-based tasks. So this is our cognitive neurology lab at NIMHANS. We have a room which has a little kitchen. We have a little bedroom. We've set up a little shopping center, so where our illiterates can walk in. And we've developed we did a literature search. We looked at different ways in which people were doing performance-based assessments. And we have now 3 tasks that we have piloted. So this is the cognitive lab, and then there's a lab, and there's a corridor, and here near the lift we set up the shopping center. And so we have developed a checklist, scoring sheet, and how do you actually measure their errors. We've come up with 3 tasks, which are cooking task, packing a bag for 2 days, and a shopping task, which measures memory, navigation. And this is actually working quite well. We've just completed a pilot of 52 people, and we find, based on our preliminary observations, that they're feasible for assessing cognition. We were able to diagnose dementia, even mild cognitive impairment. We were able to find some differences between MCI and healthy normal people in naturalistic settings that we developed in our hospital. So we would like to continue to do this and make and prepare more ecologically valid tasks for our patients. Now, moving on to culture. This was a lady who came to us, and her daughter said, "My mother talks nonstop but does not make sense." She had very fluent speech, repetition of the same theme, severe naming difficulty with ritualistic behavior. Any question you asked her, she would say, "You know, you tell me," with some poverty of words. And when you asked her, "Are you hungry?" she said, "What is hungry?" So she clearly had a semantic memory problem. She could not identify many of these pictures. She called all the animals goat, cow. The goat was a cow, camel, giraffe, pig, and crocodile was a cow. None of the non-living things were cows. This is a cow. This is a man. I don't know if you have seen this patient. It's a very, very old experiences of ours, but I think there will be some students who will, still who'll get inspired to do something new when they see their patient that is more relevant for the patient. So when we use the Cambridge Semantic Battery, which tests category fluency across these categories, she could only name 10 vegetables, but nothing else in the other categories. Now, when you think of an illiterate woman who's living in a village near Hyderabad, what is her world made of? So she is religious. We asked her to name gods, and she came up with so many names. We asked her to name, these are our gods. We asked her to name food items, and she came up with so many names. So it's really important. Then we came up with an Indian semantic battery, which is working quite well again for our patients to evaluate their semantic memory. And we're now able to make a diagnosis of semantic dementia in our patients. Prosopagnosia in a patient with stroke, you have to innovate and use and make stimuli from the famous people in their context. For primary progressive aphasia, linguistic typology is so important. And so the language tests for that, you have to become a linguist, understand Indian languages, your own languages, and then pick up signs in patients that will tell you, this person has progressive aphasia, and for that you have to pick up agrammatisms in your own language. You have to understand linguistic typology of your own language, and this is what we did. We've come up with novel tasks of syntax, and we find, since Indian languages are very rich morphosyntactically, actually our non-fluent aphasics, they speak quite well with adequate content, because we have case markers and grammatical morphemes which seem to be preserved in day-to-day conversation. So you really have to do testing to pick up these agrammatisms in our languages. So with these range of tests, we are now able to, look at the types of dementia that we have, speak a little more about our stroke vascular dementia subtypes, collaborate with other Asian countries to talk about the cerebral white matter lesions in 9 Asian cities. But when you come to the era of biomarkers, there's such an uncertainty regarding the appropriate combination and application of biomarkers, and demography varies across the world, and we really do not know how biomarkers will be, how useful they will be in people with such variability in their ages, in their comorbidities. And clinical trials as well are very unevenly distributed. And so we really need to bring our populations into clinical trials using proper methods of diagnosis. I know your lab is really in the forefront of genetics of Alzheimer's disease. it's taking us a long time now to, to understand the genetics of Indians, South Asians, because our genetic landscape is so diverse. We have genetic imprints of European, Asian, and even rarely African genomes, huge amount of diversity within India. And so this is our frontotemporal dementia registry. We have few pathogenic variants and so many variants of uncertain significance that we will really need to engage with to find out what pathology a patient has. Moving on, finally, it's important to prevent dementia, and that's what your lab does so well. And how does diversity impact prevention of dementia? We know that education, occupational complexity, physical activity, diet, they're all thought to have a moderating effect on neurodegeneration. But if you look at all these factors, they vary so much across the world. And therefore, each population is likely to have its own set of protective and risk factors that we need to understand. We were able to demonstrate that bilingualism delays onset of dementia, but the practice of complex skills is also found to delay the onset of dementia. And therefore, finally, we have a large proportion of people who are engaged with skilled work, agricultural work, crafts-related work. And this is a weaver who could be illiterate, whom we are testing on this, very simplified test. But while he's actually weaving these very complex patterns. So he makes a design, he makes a graph of the design. He might not be using a pencil and a paper, but he's developing how do you set up a loom using complex calculations, visualizing the sari that he's making, changing and innovating to the next design. So we think that for people with complex skills, there has to be a paradigm shift in understanding cognition. It has to be grounded in embodied skills, complex sensory motor skills. So we're kind of struggling, but we're trying to develop a skill-based cognitive test battery to evaluate cognitive functions among people with complex skills and varying literacy levels. There's a lot of conversation and dialogue about how important brain health is across the world. The World Health Organization there's a call out for every country to make brain health a priority. The Alzheimer's Disease International, the World Health Organization is also, calling out for a dementia action plan. And the first step for that is actually for us to make a proper diagnosis. We are doing something called the Karnataka Brain Health Initiative, and we find that many people in the rural areas are not accessing health services. And I think the challenge for the first step really will be to increase awareness and make proper diagnosis in these people so that they get the care that they require. And therefore, to conclude, dementia is multifactorial in pathophysiology, complex clinically, interdisciplinary in its management, collaborative in research. Diversity has an impact on all aspects of dementia diagnosis. And we really need to challenge dementia through studying complex interactions in so many of our diverse populations. With this, I'll stop. This is the team of people, our patients who inspire us. And thank you very much for this. So I'm ready to take any questions.
Thank you so much. This is so wonderful, so inspiring to see your presentation and all the work you have done in your country, in your community, and it's a great example for the entire world. I have to tell you, I'm very inspired seeing all that you have accomplished. And yeah, congratulations. I am also very inspired by you, a woman in your country.
No, a disclosure. Most of this work is done by young girls and boys like you who know the patients, and they will tell me this stimulus works, that one works. It's a host of people who are there to want to help their own older people who are actually helping me to do this. Yeah, but yes, thank you.
Yeah, no, it's really, really inspiring. So I invite all our audience today to please put your questions in the Q&A. In the meantime, I can start with some. Again, I know I actually took notes and so many questions for you, so I hope people will ask more. But in the meantime, in terms of the multilingualism, because it's so amazing to hear you speak 7 languages and so many people there speak different languages. And I know that the research and the literature is mixed regarding the protective effects of this multilingualism and all that. What has been your experience in India regarding the effects of, speaking so many different languages on the risk and prevalence of dementia?
Yes. So I did not choose to speak on that topic. I know that that is the topic of much interest. But we have done a fair amount of work in that. So I think that if it is, I mean, the current thinking is that it's a social linguistic context in which you're practicing bilingualism, that it might be protective. You have to be in a society where where everybody's speaking many languages, and the different languages have the same value in society. And you have to, and it's also about language use. So how much you use it, and then there seems to be a protective effect. We are still struggling with the effect of education, and because many of our monolinguals are low literate. So I think the jury is, well, since then there have been so many different studies. For instance, studies from countries like in Europe, bilingualism has been found to delay the onset of dementia. In Wales, in Scotland, in Luxembourg, in China, from Asia. So consistently, there are protective effects being demonstrated from countries where bilingualism is more of a norm. But in Canada also, but the Spanish American speaking community in America, the results have not been that favorable. But I think there is more work going on now. There is the HABS HD study, the Mexican American bilingual population, where there is a beneficial effect. So I think in North America, we need more data and we need more evidence. But from countries like in Asia and Europe, it seems to be unequivocal at this point. But I still wonder, that education is still bothering me a bit. So we'd like to work more on it. Yeah.
No, thank you. We have a question from Jairo Martinez. Um, he wonders if you could speak more about the development of these skills-based cognitive tests, given how diverse people's abilities may be.
So we are looking for good cognitive psychologists to work with us on this. It's work in progress, but it's very exciting. I don't have the answers, but I definitely think that they have cognitive skills that we are not tapping into. It does delay onset of dementia. Now, what those abilities are is something that we don't know yet. So I don't have evidence. So you'll just have to wait.
And along those lines, actually, I was taking notes from your presentation, and it's so amazing what you have developed in terms of the diagnosis, the screening. And I was wondering now, for example, because with the new drugs now, staging dementia is so important. Like, what are your thoughts about ways of testing for the ADLs and the stage between MCI, mild, moderate, once these medications become more available for everybody around the country and the world, around the world?
Our experience with doing clinical trials about maybe 10 years ago, when we were doing actively clinical trials, was that illiterates were excluded. So in clinical trials that came to India, illiterates were excluded. Then I did not have the confidence to say so. Now I have reached a point where I pretty much say whatever I want to say. So it, so that is one problem. Whether how the inclusion criteria are going to be set is going to decide really, because we have to do clinical trials first before we start using that drug. But having said that, we are all clinicians. You are also a clinician. You can stage dementia. You know when somebody has mild dementia, mild cognitive impairment. So I think we will be using the clinical dementia rating scale. The CDR is fairly a fair tool. So CDR is not a problem. We use it quite well. And most of the trials are just talking about CDR sum of boxes and a basic cognitive test. So I don't see such a problem for using it to monitor response to treatment. I think, which I did not mention, the reason we need to make a better diagnosis is for management, for rehabilitation, for cognitive stimulation therapy, for caregiver. The biomarkers will just say they have dementia, but they won't tell you for caregiver how to manage if he's losing his way. Or if he's not able to identify his relative, what should be done? So I think there's a lot, 90% dementia care is still knowing the person and knowing his abilities and disability and providing care for that. So that that biomarker is going to be important, yes, but we also have to develop multidisciplinary care. And I think for that, CDR won't be enough and these tests won't be enough. So I think it's still going to be clinical.
Yeah, it's so wonderful hearing you because you bring that humanity. That is what the reason we all do this and we care for our patients, and knowing that each person with dementia is unique and their families and their situation. We have a question from an attendee who is wondering, for those that are bilingual or polyglots, if you have the resources in multiple languages, do you consider testing in a mixed language battery? Would there be any benefits of assessing dementia with a mixed language battery?
Right. Mixed language responses will be fine, I think. Conducting the test, I don't know much about mixed language batteries. I think Sana Franzen has developed a multilingual naming task. So actually, I shouldn't say much. But in clinical practice, I think we are all using mixed language batteries only. So when I'm talking to a patient, he speaks Hindi, he speaks Telugu. So I'm probably doing it already. And I think all of you are doing it. If you meet a person who speaks Spanish and English, you're probably using a mixed language battery. But to validate and standardize and publish, it's going to be so variable. And this is work that some clever person, youngster, should take up, I think, to, it's important to get the best cognition out of the person that you're seeing, evaluate them properly, right? So, yeah, I don't know about mixed
Well,
language.
many people are inspired by your story and what you have showed us. And someone is wondering, in terms of the cognitive neurology lab, how much time did it take to become a reality? So actually, maybe you could share with us some of your story, like how did you get into that and become successful at doing your research there?
If this invitation is out to my lab people, I suspect that anonymous attendees from my lab, because it was very difficult. It was, this was not funded by our regular funding agencies. We got funded by, there is a furnishing company called Lowe's in America, right? Do you know of Lowe's
Yes.
Furnitures? Yeah. So they are a corporate social responsibility. So we said we want to develop what is called a dementia design studio. Sounds fancy. But that's what we want to do also. We want to set up environmental modification. When patients come in, we want to tell them to bring in pictures of their homes and, help them in the rehab and tell them what to do to change their homes, the color and the furniture and obstacles and all that. So with that kind of a philanthropic funding, we were able to set it up. There is a lot of literature. So if we did a literature review, so we can send across that. We went through at least 100 articles that have looked at performance-based assessments. And Then it's not difficult. It was few months, I think, 3-4 months to actually do it. And we see, now we are doing it as a pilot. I don't know what you neuropsychologists will say when we write it up. So it's still, I am not, but you know what, it can be variable, but we are trying to be very rigorous in the way and I find it very useful. For instance, I don't know if I have time. If you, for instance, this is packing a bag for 2 days. So you have an Alzheimer's disease patient who'll put in a few things, but it won't be very bad. They'll still put in some things they will not put in. But the frontotemporal dementia, semantic dementia patient can't recognize what she is seeing. So she was putting in a, iron, you know, the way iron your clothes. She put that. We had lots of we have five actual items and 5 distractor items. So she would just put in. A person with perseveration would just put everything into the bag. So just watching them, we could make instead of taking a detailed history, yes, we do that, but just watching them there, we can pick up so many compulsive behavior, environmental dependency, utilization, executive dysfunction, semantic memory loss, and that navigation task, visuospatial memory. So for us clinicians, it's a good task.
Can I ask a follow-up question there? Like two follow-up questions, actually, if I may. The first one, sorry for the interruption. I didn't want to interrupt, but this is very fascinating. So once, like, I was not the anonymous attendee, but I think that it was a really important question to ask. And have you actually published that information? I think that for the younger people and the people that are actually in training, I think that is a very important piece of information to be shared. And it will be great if you consider in the future just to, you know, like to share your experience with the world. So just something that I wanted to mention, if it is not, just consider sharing your experience because it's very unique and it's very inspiring. So like, I would encourage you to consider that. And if I can help you some way, so just let me know. And the second thing is like,
you're on board then. We want help from a proper clinical neuropsychologist.
yeah,
We're doing it to our best of our abilities, our neuropsychologist also. So offline, you know, we'd be very happy to help.
There. But the question that you were describing with the patients, I think that is also very, very interesting. And I was kind of like wondering, like, when you see a patient for follow-up, like how often do you follow up with these assessments? Are you doing like every 6 months, every year? Like how often are you following in the clinic? Thank you.
Yeah.
And then.
So in the pilot, we wanted to look at inter-rater reliability and intra-rater, because I think an internal consistency, because these tests are otherwise quite variable and they are quite consistent. So we give them it's actually not, we're giving them a shopping list, 7-word list recall. So it's just a neuropsychology. So these are the things you must buy. So we name them. Only thing is we give them a bag and a wallet with money. And we tell them, go, very simple, go out, turn right, turn left. And then he has to buy. There are 5 of those items. There are 5 not distractor items. So he has to go and he has to. So what cognitive processes are going on are different from those tests. But we have a memory test. We have spatial navigation. And then the shopkeeper asks him, do you want this? Do you want this? Do you want this? So there's a recognition task there. So they are quite consistent. We did it in a gap of 3 days. We haven't done the second part. It's 6 months old. So we've done the same thing in a gap of 3 days. And they are consistent in their behavior so far. Yeah.
Yeah, this is fascinating. Well, we have a few more minutes, so maybe we can give you the 2 last questions. One person is asking, what methods do you use to assess quality of education?
We don't. And nowhere in the world anybody does. It's a convenience variable. We happen to key it into our data sets. And we say 3 years, 5 years, 8 years. I really think the reason education is, but I also think education is the single most important protective factor. It's not to say education is the most important protective factor. So in India, it would be public school, private schools, rural schools, urban schools, slum schools. Slums are areas where really poor people live together, and days of school, and then the teacher-student ratios. And then I have done a study where we observed about 600 children for bilingualism, practices of teaching. Now, a child speaks a language at home, but they come to school and they're taught in some other language. They don't learn. So they have to be taught in their mother tongue till they are at least 9 years old. There is clear evidence that you have to learn your science and math basics in the language that you speak at home for you to learn. Otherwise, your concepts in math and science and humanities is also poor. So we have done classroom observations. And yeah, so there are several qualitative ways and some quantitative measures that will look at quality of it. We have not looked at it systematically. Bilingualism, we're looking at very systematically now. But education, so to some extent, yeah.
Wow, that's really fascinating. And then lastly, we have a geriatrician who wonders about the Rudas test. And yeah, what's your opinion on that for less educated and or those whose English is not their primary language?
I haven't used it, but I know they use it in India and it's used widely in Kerala especially. So I understand it's a good test, but I have not used it. But I know some of my friends. Yeah.
With that, we thank you immensely and congratulations. You really are doing wonderful work and you are an inspiration for so many younger people and women. And really, I am so happy to have met you today and thank you for doing all of this amazing work.
Ditto to all of you.
Thank you so much.
Especially, and today, Liliana. Thank you for inviting me. Yes.
Thank you again. Thank you so much. And we can follow up by email.
Yes.
Thank you.
Thank you.